Great to be here.
So last time we talked about the perspectives of, it's good water?
It's great water.
Cold, refreshing?
It's cold.
Did you put ice in it too?
There is ice in it, yes.
Well played, well played. Very refreshing. So last time we were here, we talked about the perspective psychiatry model.
Yes.
And you asked a very good question. You're like, well, how do I ask about this? And the thing that I wasn't able to explain is that what we do is we do an assessment, and then after the assessment, we try to formulate a patient. And so when I was a resident, it was a big part of the exam. We'd have these oral exams, and they still have them now. And we used to use this biopsychosocial formulation. And so this is a guide. It's by Campbell and Rohrbar. Well, we'll post it in the comments. But it's a basic understanding of how do you understand a person.
Okay.
So the part that we were talking about when we talked about the dimensions,
Yes.
we were talking about what do you do with the information you gather.
Right.
And you had a great question because you're like, oh, this is a cool model. Let me ask about it. I didn't go through the questions you asked for it. And what we do actually in psychiatry is we do a psychiatric assessment where we have a bunch of questions. There's what we ask, right, which is pretty easy to sort of memorize over time. And eventually, as people start to do it a little bit of times, you help them figure out how to ask it a little bit better.
Right.
Right? And then once you get that information, you formulate the patient in terms of trying to understand, the current situation, how they're responding now based on what happened in their past, and what are the biopsychosocial predisposing, precipitating, perpetuating, protective factors that put them in this situation. And that's what we typically do in psychiatry. And then the perspectives is just another way of understanding.
Okay.
And the part that I want to talk about today is the psychiatric
that book looks thick.
interview. Yeah.
Okay.
I mean, I haven't read it in years, right? So it's been years since I've read it. It's called...
But you have read it.
I think so. It's Psychiatric Interviewing, the Art of Understanding, a practical guide for psychiatrists, psychologists, counselors, social workers, nurses, and other mental health professionals.
Okay.
And I would argue a caseworker
Caseworker
is a
sounds
mental
like
health
a mental
professional. It's written by Sean Shea, S-H-E-A. And I really love this book. And the reason I loved it because it, you can memorize lists, you can memorize questions, but this really gets into the how. How do you do the assessment? And for today, what I thought I would do is, because I need to have some kind of reference for this anyways, is to go through the main components of the psychiatric interview.
Okay.
So you sort of know them, and then maybe we can decide afterwards if you have questions about it, or if you want to teach me the caseworker assessment, or if you want to teach me the GAIN. I keep bringing it up.
Yes, you keep bringing it up.
Eventually, I got to learn the GAIN.
Yes.
Although I heard it's proprietary, right? So there might be rules about when, where, how, what, who.
Yes.
When, why.
Yes. This is a lot of different owners of the GAINs. So
a lot of different owners of the GAIN. And then I thought after the session you might have some questions, right? And I thought it would also put the context clear, right? So this is the kind of assessment I do usually when I have about an hour and 15 with a patient.
Right.
And because I have a very MI-ish approach, it's the time that I see them again that I really fine-tune the recommendations.
So this wouldn't be your first, you're not doing this when a patient's in a hospital bed, essentially you're not doing this at a bedside?
Rarely at the bedside, and if it's a bedside, it's more around what the question is. So if they might be asking me, oh, is this person delirious? Are they in alcohol withdrawal? Are they depressed? Do they have psychosis? Whatever that is. Then it's a much more focused assessment on the here and now and what they need. And sometimes in the hospital, and you've seen it, people can't talk. They can't talk for more than 30 seconds. They're like sick, they're not well, they're vomiting. And so sometimes it's just a 2-minute interaction with them.
Right.
But then the rest of the time is spent in the chart, talking to the nurse, all that kind of stuff.
So it's more kind of second or third meeting stuff where you're doing that deeper dive.
Or it's the first meeting in an outpatient clinic, right?
Okay.
So someone gets referred by a family doctor. A lot of people have outpatient practices.
Right.
It's not going to be a RAM model where it's drop-ins. It's usually a scheduled appointment, usually for an hour, hour and a half. For me, I book about an hour and a half because I need time to do the paperwork, a little bit before and afterwards.
All right.
And I'll just cover that.
Okay.
So the way it usually works is so somebody sends a referral to whatever clinic or organization that you work in, and then they schedule an appointment, right? And now it could be either virtual or in person. And so when the person comes in, the first thing that you sort of do is you set the frame of the interview. You explain to them what you're meeting for, limits for confidentiality, when you have to report them, all that kind of stuff. And you just sort of make sure that they're aware of all of that. You also make it clear whether it's like a one-time visit or a couple-time visit. You want it to be as clear as possible in the beginning. When I started doing it, I would do more like a general conversation, but I found the more structured I became, the better my information gathering was. And so there's some people that do 3 or 4 part visits that are less structured, the person really feels heard, all of that kind of stuff. But it just makes it hard to do that efficient psychiatric assessment piece.
Where are the answers being written? Are you doing this shorthand? Are you?
Yeah. So what I do? So back when I was a resident, I would have a blank sheet of paper.
Okay.
I would divide up the paper into sections, and I would just put scribbles of the different parts. And then when I was done, I would just go type it up.
Okay.
Now what I do is I still do scribbles, or I'll type up just point form notes.
Okay.
And then I pick up a phone and I talk into it.
Okay.
I've worked a couple places where I type while I speak, but then after every 30 seconds, I'll be like, I'm just going to make sure I capture what we said, and then I shut it for like 15, 30 seconds. And then I said, okay, let's go to the next question.
Okay.
But there's a whole sort of system in that. And if I don't have if I have my process notes that I take during the interview, even if I don't dictate right, I'm sort of okay. But if I don't take proper notes and I don't dictate right away, I don't remember the story very well.
Right.
So it's very important that you capture it and then you have a way of documenting.
So it's not something you're coming back to 3 days later and writing the notes. There's notes by the time.
Yeah. I mean, usually it's about 20 minutes after the person leaves. You try to get it done. And the place I work now, I dictate into a phone, and then a day or 2 later it shows up in the system, and then I have to edit it.
Okay.
Right? But if the dictation is there, then I'll know the story.
Okay.
So when you're seeing somebody, and we'll post a blank template for this, and you know what I'll also do? The Royal College, and it's available for free, I think, on the U of T psychiatry website. They actually have the evaluation forms.
Okay.
So the evaluation forms where we tick off what the resident asks, and we also tick off how they ask it.
Okay.
So.
And that's something we can post, you think?
Yeah. It's
Okay.
you can Google it. If you can Google it, I think you can post it, right? If it's not proprietary.
Yep.
And it's what all psychiatry residents have to do to pass their exam.
I think
it's a little bit cluttered.
That's interesting.
Yeah, I mean, it might be interesting to look at, but you'll also see when you see it, it's just not practical to do when a person's intoxicated or in withdrawal. There's no point to it.
Right.
But when you have someone who's come to a few RAM clinics, maybe they detox, maybe they have periods in the day that they're sober, they can sit for an hour and have a conversation, then you can go through the history, no problem.
Okay, that's interesting. So from an addiction, because primarily that's what we're talking about is addiction. So from addiction perspective, you're looking for someone to be not necessarily free of their substances, but not intoxicated on their substances while they're with you.
Yeah, like I need like 60 minutes where you can talk like me and you are,
Okay.
right?
All
And
right.
people like me and you could be addicted, but if we were addicted in the room, the conversation would be very different.
Right. Okay. And,
Right.
And you're not. It's going to take. It could take considerably longer, and still not be as effective either.
It might not take longer because I'd condense it to the key points. It would be more of a focused assessment.
Okay. Got it.
So this comprehensive psychiatric visit, I mean, this is what allows me to figure out what the diagnosis is, what treatments they've had before, what they haven't had before. And it also helps come up with a roadmap about what it might take for this person to get better over the next 1, 2, 5 years, whatever that might be. And it might also be something that helps you figure out what can complement the stuff they've already tried.
Okay.
So it's very structured. So I always start with identifying data. So I ask them, their name, date of birth. I could ask age, depending on how my memory is that day, who they live with, are they in a relationship, any children, how do they support themselves financially. And if I get something that I'm genuinely curious about, I'll ask about it, just because it's sort of like, how you do the thing where if they have a sports team or something else, you want to build a bit of that rapport, I'll ask a little bit about them. And if there's something that I'm genuinely impressed by in the stuff I'm hearing, and I'm curious, I'll have some curiosity for that as well. Because, people, like in psychiatry, sometimes talk so much about people's negatives, they don't get to share their strengths.
Yep.
I sometimes ask why they were referred to see me. Was it for pain? Was it for substance use? Was it for opiates? Was it for buprenorphine? Was it for opiate tapering? Was it for psychosis? Whatever that may be. And the way that I do it, although which might be different or similar to other people, I say, what are your biggest challenges right now? What's affecting you the most? I get a list of things. I figure out how long that they've been going on for. And then for the history of presenting illness, I go through each one of those symptom clusters in terms of when they started, how long have they been there for, how they're affecting them. And I try to get a narrative more recently, but I also try to get that timeline that's a little bit longer term.
Okay.
I have them share if there's any precipitating, like any factors that made it bring up, any stressors that are making it worse, stuff in the environment that's hard to cope. And my favorite question, I don't know why I love this question so much, I really try to get people's typical day. I just want to know when they wake up, what they do, then what they do after that, what they do after that. And when people were to ask me, oh, is it that way you can fare with their substances? I was like, no, that's how I can know what they care about. You know, like if you're coming wherever to record this like podcast, or if you're like watching a movie, or if you're like on your phone playing a game, that's going to be more important to you than anything else in that moment, right?
Yeah, I've heard you ask that question to patients,
Yep.
and I like the responses, because it's sort of it also you can tell a lot of what they care about. I guess that is what they're talking about, but also that it sort of gets them doing a little bit of storytelling, and you sort of see where that goes, right?
Yeah.
And it's
Yeah.
And people like to tell a story. We all like telling stories.
Yeah, maybe
right?
that's it. Yeah, and I mean, I'm so curious about that typical day too, right?
Yeah.
Like what they do on a bad pain day versus a good pain day. What do they do on a day they're using versus a day they're not? And some people actually have good days and bad days, and they know them really well.
Yeah.
Right? And I love hearing that contrast and that narrative. And as people are going through that, the back of your mind, you're starting to think like, oh, is this more where there's situations where the person responds to? Or is it an internal state that they can't change? Is it a combination of both? Is their buffer extra small where stuff they could normally deal with they can't? But for me, that's really what brings out the history of presenting illness. And for me, I think without that narrative around what happened, I feel it's just a whole bunch of symptoms. You know, like, oh, I drink, I can't stop. Oh, I'm depressed, I can't stop. Oh, I've had racing thoughts and I can't sleep for 3 days. If I don't know the context,
Right.
I feel like I don't understand the person.
Right.
And by understanding the person, I feel we can come up with a plan for them.
And so that's a question you tend to ask earlier into these assessments to get a picture, a roadmap?
Yeah,
Okay.
I sometimes even ask before I get the HPI.
Okay.
Just because I want to know what their baseline state is. Like, what's your day like? Because every depression is so different. Every depression is so unique. I go through those what's like sleep, interest, anhedonia, guilt, I don't know, concentration. Like, I go through those questions. I mean, it tells me nothing if I don't know the context.
Right.
But that's me, right?
Yeah.
Like, so I've seen tons of great psychiatric interviews, and they go immediately through, oh, the depressive symptoms, but I save those till later.
Yeah.
So I go through the history of presenting illness, including the precipitating factors, I get the typical days, and then I go to the past psychiatric history, right? So first contact, what was the diagnosis then? Did you end up in hospital, safety, any med trials? I always ask about any bad side effects, like ever.
Okay.
You know, people want to tell you if stuff worked or didn't work, but I just want to know if something was horrible for you. You had a horrible reaction, because I need to make sure I never do that again, right, to them. I also ask about different counselings and therapies. Were they helpful? Were they not? How they worked? All that kind of stuff. And depending on my mood, I'll sometimes ask about addiction treatments there, or I might not.
Okay.
Afterwards is past medical history, and there's a few things I'll ask in more detail about, medications, allergies, and then I'll ask about family history.
Okay.
I specifically ask around schizophrenia, bipolar disorder, suicide attempts, substance use disorders, and also depression and anxiety, because that's important too, but I try to get the big ones. Especially for people who use drugs, you know, they might have some kind of biological vulnerability, and if they have a family history of bipolar or psychosis, there may be a chance that certain meds or certain drugs might bring it out more likely. And also it changes my suspicion, right, when they have these unusual states.
Okay.
After that, that's when I go through my system clusters. And in the handout that we posted in the previous talk, I think it was from Journal or something, they divide them into different categories. So I'll just go through mood symptomatology, generalized anxiety symptomatology, panic attacks, manic episodes, hypomania, full mania. And usually what you do for these ones is you have a screening question. If it's sort of positive, then you'll dive in deeper. I'll ask about psychotic symptoms and the timeline for it. For PTSD, I try to keep it a little bit superficial, because I've had patients where I go through their history and then a week later they're very upset. You know, like, I couldn't sleep, the nightmare was back. And so the PTSD, I really just keep a couple of screening questions that are like one open-ended question, or actually they're all yes or no, 5 or 6 yes/no questions. And if there's a signal, I might dive deeper, but I usually don't.
This is to try to avoid getting into a deep trauma at a very early stage in this process with
but
your
I mean,
new patient.
Also, I want them to be in the driver's seat, right? Like, I don't want to have to out people, you know, or force them to out people. And I've worked with patients where it's 2 years later, I find out that they've had any trauma. They don't tell you. Yeah. Right? You know, and the number one things I want them to come back. But there's a primary care PTSD screen that I really like, because it's just like 5 or 6 questions. And then sometimes I might ask about the timing and stuff, but I try to keep it at that. And then I'll go through the borderline symptoms as well.
Okay.
Right? I just feel like they're very, very high yield, right? And then I'll do the substance substance use history. The substance use came up earlier. I might have brought it up earlier, but I always ask about age of first use, when they started using weekly, when they started using daily.
Okay.
What did they get out of it? What was a typical pattern? What did they go through? What kind of ways? Were they linked with any kind of behaviors? What they liked about it and all the harms?
Yeah.
And then I might ask about treatments, what they tried, was it helpful? And if they do give me periods of sobriety, I get them to talk about it in detail.
Okay.
I get them to tell me everything about it. Oh, I almost go through the typical day of when they were sober.
Okay.
And I do it from a curiosity perspective, right? Because what you're doing then is they're telling themselves all the stuff that was in their life when they were sober.
Right.
Right? And sometimes it's depressing because maybe they had a healthy relationship, maybe their kids were there, whatever that was. But then they start to get clues that, maybe I'm better when I'm alone, or maybe I'm better when I'm with others, or maybe I'm better when I'm working. And then it's not me telling it.
Right.
Right? And so that's the part that's there.
Okay.
Once I'm done that, I go through the personal history in detail as well, but I really just stick with a few headlines.
Okay.
Where were they born? Was there any complications at birth? Who was in their family growing up? What were they like as a kid? What was their temperament like? What they liked at school? What they were good at? What they didn't like? Relationships, friends, hobbies. I ask about sexuality, when they went through puberty, interested in boys, girls, or both, longest relationship. If some relationship was particularly meaningful, I might ask a bit more about that and how it ended. Job history. And then I try to ask one or two questions about their understanding of things. What are they looking for? What would be helpful? Usually in the first session, I don't actually go through their full chart, because I find if I go through their full chart, I'm very closed-minded. I might already have a diagnosis, I might already have a plan, I might already have those
You
things.
might read about the 5 diagnoses they've already received and be influenced by that potentially.
Perhaps, I mean, subconsciously.
Ideally,
maybe,
you're not supposed to be, but
ideally,
it's
I
still,
won't be.
you're human.
But I want to come up with my own approach, and sometimes I miss things, and sometimes I don't. And then before the next visit, I try to go through the full sort of history. If I have a clear idea around, like, I might ask, do you have any questions? Anything that we didn't talk about that you think is important? Anyone else I should get information from? There's some things that I'll ask depending on how it is, And if it's the time to give them a diagnosis or recommendations, I'll ask, so in motivational interviewing, they do a thing called EPE, elicit, apply, elicit. So I might say, can you tell me what you think's going on? What do you think the diagnosis there? Would be interested in hearing the things that I've been thinking about. If they say yes, I might share it with them. Then I'll ask them what they've heard. And for the treatment recommendations, when I use the EPE approach, it takes about 15 minutes longer, then I know what they're willing to do. Can you tell me what you know about treatments for depression or alcohol? They'll tell me a bunch. Would you be interested in hearing what's worked for other people? And then I'll share with them. So if I say there's this med, I don't want meds, I'm not going to push them for meds. I'll still have to include it because I'm a psychiatrist, and that if that's best practice and it's indicated, I have to be able to say it. But then I don't spend my time fighting them on the recommendations they don't want, but I just make sure that they're aware of it.
Okay.
I think that's really it. It's not that special, right? And then for the treatment plan, there's ways we divide it up. You'll have a diagnosis, you'll have a differential about other ones that could be there. You'll have a narrative around what led the person to be this way. And for the treatment recommendations, you might divide them into short-term, medium, long-term, safety, medications, therapies. There's many different ways to sort of do it, but that's sort of what I go through there for it.
Okay. Now, since we're talking about addiction, can I just ask a question about that?
Of course.
Okay.
Yeah, go ahead.
So, so much of, as we were talking a little earlier about, you don't want to have someone intoxicated, but also so much of psychiatry from, not necessarily work that you and I have done together, but work I've done with, with psychiatrist colleagues that you have and in the industry, saying they want to get the individual free of their substance use before they do these assessments. What are your thoughts on that?
I don't know. I wasn't trained that way.
Okay.
Who's going to do the assessment for them then? Are you going to send them to an addiction person to do the assessment?
Well, no, there won't be an assessment until, because they can't really do a fair assessment while someone's intoxicated. Not while somebody is deep into their substance use. It's hard to get.
I mean, I can't tease out if they have like a bipolar spectrum or a psychotic spectrum, but I can still do an assessment. Mm-hmm. I can say alcohol intoxication. That can be my assessment.
Yeah, well, I mean, but I'm saying this is not the first time you've heard this.
No. I guess what you're saying is that people might be saying, I can't diagnose a depression, or I can't diagnose a bipolar, or I can't diagnose schizophrenia if they're using substances.
Yes.
They'll still see the patient, but they can't get those answers.
Correct. Yeah.
Yeah, no, and that's fair. I mean, there's nothing wrong with that. Sometimes, you know, once you've done it for a while, and once you have histories, once you have like time they might have been seen when they were sober, once you start to get the longitudinal picture,
Yeah.
and you can get the pockets of time where they were using substances, the pockets of time where they weren't, whether the substance use is before, during, or after like a manic episode. You get collateral like from family and friends around what they're like at different times.
Yeah.
Then you can start to get signals, right? And so if you have a family history, you start to get signals. And so, for example, if I'm seeing somebody and they have symptoms of depression, I mean, there's a reason the docs say that. The reason the docs say that is because historically, when you detox somebody from alcohol, 60 to 80% of them, their depression symptoms disappear, right? And so, and then the reason...
It's fair. I'm not saying it's not fair.
But the reason that I'm saying what I'm saying is that, like, but what do you do for the people that can't detox themselves? So obviously, sure, somebody comes in saying, hey, I've seen you, you're clearly depressed, you're drinking, why don't you try some time stopping? That's fair game. But what do you do if they can't stop?
Right.
Right? And that's where having this more integrated approach definitely comes into play. This is also where other things like family history are helpful, or there are certain meds that family members have responded to. What were they like in their teens, back when they're sober? Maybe they've been depressed for a really long time. Is it like, are there some symptoms get better or worse with the substances? Are they able to focus better, or do they become psychotic, or do they become anxious when they use cannabis? All these things give you clues, right?
Yeah.
And then you want to move them into a direction and maybe stop the biggest harms first.
Okay, are we getting into an area where this is why somebody with substance use would see an addiction psychiatrist versus a regular psychiatrist?
I think in this day and age, you see any psychiatrist that'll see you. Like, how do you find these addiction psychiatrists?
Well, that's true. You're a rarity for sure.
Well, no. I mean, there's a bunch at CAMH, a bunch everywhere.
You're a rarity to be as somebody who is trying
who identifies as that, yeah.
Who identifies as that is and to get an appointment with such an individual is.
I'm an addiction psychiatrist.
Right. So as somebody as somebody that supports patients that would believe that an addiction psychiatrist is the holy grail of where they're
Who
going.
believes this? Where are you coming up with these statements? I don't think there's anyone that believes an addiction psychiatrist. There's people that believe the opposite. That I know. But sure, like, okay.
All right, let's go with this analogy.
Let's pretend.
Let's pretend
that
these
some
people
people
think that
you
you've got
need
all
an
the
addiction
answers.
Psychiatrist,
right?
To fix and solve a problem. Let's assume that.
Right.
Okay, go ahead. Yeah, good.
But I guess you could say from this conversation, is it fair to say that you're more willing to engage a patient that is deeper in their substance use than perhaps the average psychiatrist that doesn't identify?
Maybe not. I don't know. I mean, I think some people will still see the person,
right?
But they just can't. I mean, the problem is when people are heavily using substances, they don't come to appointments. So the assessment I went through was like it was a 60 to 90 minute. I mean, I did it in like 2 minutes, but it's a 60 to 90 minute assessment, right? You have to make the process such that the person feels comfortable, they trust you, they're willing to share, and you have to follow through and with that trust, you have to perform. Yeah. And so I think like when you think about an assessment, I mean, there's so many lenses to look at it, right? So emergency docs will assess people that are suicidal.
Right.
Family docs will assess.
Of course.
Emergency psychiatrists will see someone that might be suicidal. What's it called? CL psychiatrists in hospital, they might see someone. I might see someone. I might be doing therapy as an outpatient with someone who's already been diagnosed with suicidality, and then you're working with them over the course of 6 months to help them find that, to shift if that's what my point is that there's so many different things that are involved in an assessment, and all what I shared here was that sometimes when people have a period of sort of stability, so maybe they can talk for 60 minutes to 90 minutes and they're not actively intoxicated or in withdrawal, you can get some very good information from them and you can give them very good treatment recommendations based on what they're going through. And if where you work allows for it, you can meet with them and work with them to improve their life.
And if you've got a patient that's suicidal, and regardless of where their substance use is at, you're still got to treat the patient that's in front of you.
Well, yeah, you can't not assess the suicidality.
Say, you've got an alcohol use disorder, so I come back when you don't have it.
Yeah, I'll treat your suicidality then. No, but we're laughing a bit. But we do the same thing with psychosis sometimes.
We do,
right? Like,
we absolutely.
And it all depends on who you talk to, right? Because for some people, psychosis is psychosis. If your perception of reality is like inaccurate and you're at risk of doing something, that's a concern, right? Like,
no, for sure. I mean, that's and so a lot of times, and where I work, you know, you would ideally, you know, you would the team would try to separate you out from your substances for a period of time to see whether or not this is a underlying schizophrenia or this is a psychosis. This is substance use psychosis.
Yeah. But it's so hard to tell. It's hard to tell.
It's so hard. It's so hard to tell. But and then it's even equally harder to get the admission into these programs to get them separated from their substances, right? You know, you're not traditionally.
And that's why when you have somebody in a program, I mean, that's the perfect time to get them assessed. You know, they're in detox for 2 weeks, 3 weeks. They're in a treatment rehab center for 3 weeks. Then let's figure out how to get that assessment done.
Okay.
You know, so what I covered today, just a quick sort of summary. I talked a bit about the psychiatric assessment.
Yes.
I didn't go through the formulation, but I talked about what it was. And we'll share the link for the formulation. We'll share my favorite book for how to learn the psychiatric interview, and it's not as bad as it looks. And I'll also share the marking sheets we use at U of T and throughout the country to evaluate how a psychiatrist is doing their assessment.
All right.
And when you see it, you'll see it's really overly inclusive.
All right.
And then we'll decide what's. Are we trying to end this? Are we trying to finish our session?
No. We got 4 more minutes.
Okay, and then let's see what.
I'm not giving you the wrap-up signal yet.
No, we'll see what we do next, right? Because I think it was just important to have just some kind of a verbal overview.
Yes,
of what's involved in the psychiatric assessment, right? But I didn't cover what you do with that information. I didn't cover a bunch of other stuff. But I just wanted to.
Well, we're not going to learn all of psychiatry in a 30-minute video.
Sure. And then the other thing is that's really, really important for the interviews are we say content or process. And content is what you ask, and process is how you ask it.
Okay.
Right? And I think those things are also extremely, extremely important.
Yes.
And
well, in all our work, and I mean that's so much of what we do, right? Is what you ask, but then how you ask it. That's very key, right? So it's not just a psychiatry lesson there.
Yeah, and sometimes you have to ask the same question in 3 or 4 different ways, like indirect ways, before you get the information you're looking for.
Yeah, 100%.
Right, and we've seen that with sometimes with each other.
That's true.
we have something to figure out and solve. So, well, yeah, this is good. I feel like we got a bit of we're getting a good foundation here.
I think so.
Okay, good. Let's go.
All right. Thanks.